Hello, my name is Dr. Phillip Mease. I'm the Director of Rheumatology Research at Swedish Medical Center Providence St. Joseph Health and Clinical Professor at the University of Washington in Seattle. Today I'm going to be speaking about the effect of sex and gender on rheumatology disease activity and treatment response. We know that there are a number of different factors that influence disease activity and treatment response that are above and beyond the disease itself, whether it's rheumatoid arthritis or axial spondyloarthritis or psoriatic arthritis or lupus. We know that such features as disease duration, age, ethnicity, body mass index, many other factors can influence this. But certainly one of them, as it's turning out, happens to be sex and gender. Now, sex is the state that a person has at birth. It's a biologically based construct that defines the difference between males and females. Whereas gender is much more complex and includes sociocultural aspects of being a man or woman and the effects of social norms and expectations for men and women in a given society. So we know that there are a number of features, for example, in psoriatic arthritis, which I happen to focus on quite a bit, that are different between males and females. For example, we may see more axial involvement, more severe psoriasis, more radiographic peripheral and axial damage in males than in females. And on the other hand, in females, we may see more peripheral involvement, such as joints or entheses. We tend to see worse physical function, quality of life, fatigue, and pain as measured by patient-reported outcome assessments, as well as oftentimes multi-morbidity, including depression, anxiety, conditions like fibromyalgia, and so forth. So right there, we know that there are potential differences in how patients report disease severity and treatment outcomes. So women, for the most part, tend to have worse disease severity, whether it be pain or other measures of disease activity that are patient-reported, subjective. And also, during the course of treatment trials, we're beginning to learn that women may not have quite as good treatment response. For example, males are 2 times more likely to achieve minimal disease activity than females at target of treatment. Females are more likely to discontinue treatment and want to move on because of inadequate response and that sort of thing. So there are a number of factors that influence this. For example, gene and gene expression may be different between men and women. We've seen that in numerous gene studies. The pain mechanisms may be different. So women may have higher sensitivity to experiencing pain and tend to have higher reporting of pain levels with a similar degree of external stimulus or even internal. Drug levels and distribution, so pharmacokinetics, may be different between males and females, and immune system function may be different. For example, there's a study from Toronto that suggests that differences in the IL-17 pathway in psoriatic arthritis and axial spondyloarthritis may be present between males and females. So we have, therefore, a true difference in sex effect on things like inflammation, pain mechanisms, pharmacokinetics. But on the other hand, gender may have an influence. For example, the gender role that women may play in the society versus men. Often being caregivers for mothers or fathers may influence disease activity and outcomes. The patient-physician interaction and differences in relationships between males and females may influence how a patient experiences disease and outcomes. There may be differences in work experience. And all of these things may lead to a difference in disease severity and outcomes. An example of this was a recent post-hoc analysis of the upadacitinib in psoriatic arthritis phase 3 trial, in which it was noted that women tended to have worse disease activity measures at baseline, and over the course of the study, they tended to have less treatment response in terms of ACR response. Enthesitis assessment would be examples of that, whereas measures like skin were not as different, and that's typically a more objective measure. I hesitate to blame this kind of difference on something like fibromyalgia, which we know is more in women than men. Certainly that may influence some of these outcomes, but we also are learning that there are other important biological differences that may influence this. So what's the practical outcome for you in your practice? I think it's important to take this into account as a contextual factor. And when you're interpreting disease activity and treatment response in a male versus a female, think about whether or not there might be some factors other than true biological effect of the treatment being given. For example, if the patient has 0 swollen joints, normal CRP, yet is still having a lot of residual pain and fatigue, consider other factors that may be different between men and women. And maybe you don't want to necessarily jump automatically to a different immunomodulatory medication, but think about other approaches that might be used to ameliorate some of the symptoms that the patient is experiencing. We're going to be studying this in more depth. There is a prominent study known as the SAGE study that's being led by Leahy Eder at the University of Toronto, being conducted by the GRAPPA group as part of their collaborative research network. And we'll be entering over 400 patients with PSA who are being started on treatments and looking at many different factors in the differences between males and females, biological, immunologic, genetic, as well as some of the differences in pain response. And so I think we're going to be learning a lot more about this in the future. Thank you for your attention.